lens power is plus 5.5 diopters. So it's a case of cataract with high myopia.
Yes, so she's a 53-year-old lady, so a fairly young lady. So I'm going to be starting the incision. I'm doing a 2.2 millimeter incision. So when I plan the incision, I try to go slightly 10 degrees off. So this way it is more right dominant, and then create a 2.2 incision. Try to have at least a 1.5 to 2 millimeter valve. So in a high myope, as we are aware, the patient obviously has a lot more sensation. They have a lot of pressure because of the iris lens diaphragm retropulsion syndrome. So here, normally I don't change my settings for the myopes. Again, in myopes, the capsule can be a little more elastic because they are younger and with the cataract. So the capsulorhexis here is done with the cystitome. I prefer to do the rhexis about 5.5 millimeters. So when doing the rhexis, in order to have a more circular pattern, one can place a cystitome about 1 or 2 millimeters away from the edge of the flap and then bring it forward. So this will give it more of a nice curve and a more circular rhexis rather than going too close and making multiple necks. So try to go a little further away and go a little farther. So your rhexis could be more circular. So the rhexis is a little smaller than what I would like it to be. It's about a 5 millimeter rhexis. So hydrodissection, again, the chamber is deep here because the patient is in a myope, hydrodissection and delineation. So we can see a golden ring because it is a nuclear sclerosis grade 2 with more of a subcapsular and some cortical spokes. So the factor in a myope is either one can go ahead and change the settings and lower the bottle height and things. But here I'm using the Centurion machine. I'm using the active sentry here. Myope is set at 44 and using the balance tip. So it's about 475 vacuum. So I don't change my settings even in myopes because one can release the capsule iris addition by using a spatula before introducing the irrigation, either with the phaco probe or the IA probe. So I just introduce a spatula and one has to just lift the iris, and this way you'll find the chamber doesn't deepen. So you introduce the irrigation and the patient doesn't feel as much pressure as well. So the settings don't have to be changed. So the cataract is soft, so we don't need much energy. I'm using drops on the cornea, a straight chopper with a blunt tip. I'll be doing a horizontal chop here because it's a soft lens. So with the horizontal chop, I'm just removing some epinucleus on the surface, placing the chopper on the nucleus surface from the center, going to the periphery, supporting it with the phaco tip, and then bringing the tip towards the probe, and then separating. So you're using your probe only for your kind of a little vacuum, but more mechanical support here because it's a very soft lens. So the horizontal chop technique works well for a soft cataract like this. You can always sub-chop, you can always use your tip first as well, or you can place the chopper on the equator and then support and move it horizontally from the periphery to the center and then make it into a smaller fragment.
So what's your torsional power that you have kept as the limit?
It is 60. Is the overlay? Yeah.
Yeah.
Is overlay coming through?
Yeah.
So I've used torsional of 60. So this is the balance tip, and with the balance tip, we don't need much energy. And even with very, very hard cataracts, the highest torsion we use is 75.
Yeah.
So, and again, we also have the active sentry here, which helps us to lower the IOP further. So once the pieces are chopped and then the fragments are removed, so the goal here is to maintain the chamber. And as you can see, the chamber is very stable. I'll have the
It
pieces.
is absolutely stable.
Yeah.
Yeah,
And so
very nicely multiple pieces you have already done, and now it's coming in very easily.
Yeah,
The CD we can see here that it is just 1.7, so it's wonderful.
Yeah. So the energy is lesser, and even in a myope, there's no chamber fluctuation. It's a very stable chamber.
Yeah.
Before going to cortex aspiration, I would always, I like to, and I would recommend this step
Yes.
very strongly to enable, cortex wash. So I'm just doing another hydro dissection, a wash actually. I would like to do it below the capsule, over the anterior leaflet, if possible, or onto the PC directly.
I remember in your last Surginar also you had emphasized on loosening the cortical fibers by these jet of fluid, right?
Yes, yes.
Yeah.
At the patient. So this is actually something which will be, I'm just going to repeat that. So you use your hydro dissection cannula and just repeat it. I would do it in different quadrants. Now here there's a lot more cortex. So this will also help to release the cortex adherent to the posterior capsule and the anterior capsule. So your cortex wash becomes that much easier. Spatula. Again, every time irrigation is introduced, one has to release the iris capsule adhesion. So again, I use a spatula. Normally I use a Sinsky as a second instrument, but in the myopic eye, I like to use a spatula. So then you lift and then introduce input position 1 with the IA probe.
This is a wonderful tip. I would like to know what exactly it does, why do you like to do such a thing? People would definitely like to know, because in myopes, as you said, that you like to lift the iris.
Yeah, so I think you permit the fluid to flow. Otherwise, with the weak zonules, the iris is stuck to the anterior capsule, and this deepens.
The iris will be forced to go back.
Yeah, and the iris will be too deep, and the patient will also have a lot of pain. So by releasing this, you'll find your anterior chamber depth is normal, even in a high myope like this. So I'm again repeating the fluid dissection just to remove these few little fibers.
Yeah, we can see
on the posterior capsule.
Really, yeah.
Visco. Right. So the IOL, I'm placing a 6 diopter IOL because with the 5.5, the residual is 0.05. With a 6, it is 0.32. And a myope, even it's the Barrett formula, I like to, have a little higher residual correction. So I'm placing a 6. So I would like to have drops on the cornea. So to do a wound-assisted implantation, I would have the cartridge locked in the wound. And this is a single piece acrylic lens. And just push without stopping, without hesitating. That is the best technique to follow for a wound-assisted implantation. And once the lens is implanted, again, before aspirating the visco, I would lift the iris and then remove the viscoelastic. So removing viscoelastic has to be in 3 phases: from the anterior chamber, in the capsular bag, over the IOL, and then below the IOL as well. So all these 3 steps will ensure we remove as much visco as possible.
So this is a monofocal lens that you have implanted.
This is a monofocal lens, yes.
Yeah. You implanted with a shooter, right?
Yes. So with the shooter. So I like the shooter because it's a one-handed technique.
Yeah.
I can use a second instrument to stabilize the eye in a patient under topical anesthesia.
Yeah.
So that is the liberty you get with the
true.
With the plunger. Yeah. With the screw, of course, you'll have to use both your hands or have your assistant screw it for you.
Yeah.
Now closing the case, I'm using intracameral moxifloxacin, 500 milligram. Operation nalla panniyachungama.
Very nicely and very smoothly done case, Dr. Haripriya. We have been used to, implanting the lens with the AutoSert. Any experience on that? Mm,
Yeah, I think the AutoSert does work very well.
Mm.
I do like it, just that we don't use it for all our patients. I think the AutoSert is an extremely good device. I think it is the way forward. But this is something which we do
Yeah,
more
yeah,
common.
yeah. So for shooters, actually, do you give any instruction to the sisters, to the assistant, like, you should check whether it's moving smoothly? Sometimes there's a jerk.
So the only thing is actually with the aspheric IOL, you may have an issue with the shooter if you've been using the shooter for a long time. So what happens is the plunger in the injector may be slightly tilted, upward.
Yeah.
In which case it may go over the IOL optic, and this will kind of get stuck. And so when you press, you have to push in too much force, and this IOL may just rush out into the chamber, and you may have a rent or something. So this does not happen as much with the Actris of single piece, because it's a fairly a slightly thicker lens compared to the IQ. So I think when we have the problem, it is more because of the injector. If it's a defective injector, then this can happen. So one has to ensure the injector is fine and then use it.
Yeah, the plunger should move smoothly.
Should move smoothly, yes.
Many times, we do advise that one should always do a dry run kind of a thing. So I always, whenever I'm using a shooter, I instruct my, assistant to just check whether the plunger is moving smoothly, and then you load it. So that helps in these.
Definitely, yeah.
The way you injected was absolutely smooth. It went very nicely. So, and the biggest advantage that you told, that with the second instrument, you can stabilize the globe and keep it absolutely well centered.
Yeah, and also you can guide the optic into the bag, even if it tends to not slightly tilt or come out, you can always guide it back. So both the haptics go into the bag as they unfold. That could also be an advantage.
Yeah, yeah. And there was one wonderful thing that you showed, which, that, you lift the iris a little bit so that the iris doesn't get stuck and the AC doesn't become so deep, because it stretches the zone use, the patient has a feeling of pain and all that. So it's a very good tip that you gave.
Yeah. So I think once we do that, then the thing is, otherwise normally myopes, we used to go ahead and change the parameters and all that. But today we use the same settings, but just with this one maneuver, things can be normal. But of course, the iris can be a little bit more floppy in a myope. So there's a higher chance of pupillary constriction and things like that.
Yeah.
So the fluidics also plays an important role. So to have a good fluidic system, so your chamber is stable and you don't have too much of iris fluttering.
Very true. Very true. In a further higher myope, would you like to go for a little lower IOP? In such cases, maybe.
Yeah, actually, like I said, I don't change it. I mean, even in very high myopes, I don't change it, because I would, if the patient had some discomfort, any pain, or any pressure sensation.
Yeah.
But I don't see that as an issue. So, of course, the machine would permit us to go much lower than this. But I think the machine also permits us to have one setting for a wide range of cases. Of course, very high, very hard lenses, then I would use higher torsional and higher vacuum. But otherwise, even for subluxated lenses, myopes, I still have the same IOP, and things work fine, actually. So,
yeah, and with the good foot control, one can manage.
True, yeah. It's a combination of the right technology and the technique.
Absolutely.
So, Arpriya, do you have active sentry into your machine?
Yes, ma'am. So we do have active sentry, and that is why earlier myopia used to be between around 60, 55 to 60, and now I have at around 40. And this is because of having the sensor in the handpiece. It is more responsive, and you can bring down your IOP considerably while not compromising the efficiency. You still have the same high vacuum, high flow rate with a much lower physiological IOP.
Okay. So the second case that we are doing is with, again, a phacoemulsification with the, you are doing case 2 now?
I'm doing the
Yeah, it's
I
come there
think
on the
the
screen.
screen is, yeah, it's on the screen now.
No, it's very much there. A dense, again, cataract with a pseudo-exfoliation syndrome, with the pterygium excision, which had already been done previously with autoconj 2 months back. I think this is very important that if you're planning a pterygium plus cataract surgery, and this message goes by that you should first do pterygium excision, allow the keratometry to stabilize, and then do cataract surgery later with axial length of 23.8, cylinder of 2. And I think
Drops on the corner.
and the Alcon toric intraocular lens with this. I think this question everybody asks, that if there is a pterygium, when should you operate? Should you do sequentially, simultaneously? Obviously, in this case, astigmatism is there, which is about 2 diopters, and pterygium would have also caused astigmatism. So if you try to address that simultaneously in one sitting, then you may be little erroneous on the keratometry value. So we are ready, Harpriya?
Yes, ma'am. So we can have the microscope view.
Yes, we can see, and the marks, manual marks also we can see.
Yes. So we're using the Varion here. Start, ma. So the Varion has a option of getting an image pre-op, and this recognizes it intra-op, so that based on the limbal vessels and the iris, it recognizes it, so that we have no issue of cyclotorsion, and we have the incision and the IOL position also planned. So my incision here is going to be at 0 degrees. And as was earlier mentioned, this is a patient post-pterygium. So you can see the pterygium scar here. And it's about 2.25 cylinder, where a knife put two diopter cylinder. And we normally wait about 6 to 8 weeks after the pterygium surgery for the wound to for the astigmatism to stabilize before we plan the cataract surgery. And if there is a residual cylinder, then we go ahead and do a toric implantation. This patient, as you can see, also has some pseudo exfoliation material on the anterior lens surface, and it's like a grade 3, grade 2, grade 3 cataract.
So the pseudo exfoliation is very beautifully seen on retroillumination. I mean, it couldn't have been better than this.
Yeah. It actually is appearing like a true exfoliation.
Yeah.
Yeah. Viscoat. So I'm going to use viscoat here. So when I have a harder lens, and when there is pseudo exfoliation, can also increase the chance of corneal decompensation. Plus, with the hard lens, more endothelial damage is possible. So I'm going to be using viscoat, which is a dispersive visco, and the chondroitin sulfate helps to coat the endothelium. And it's a little modification of Steve Ashnoff's soft shell. I use a high HPMC below the viscoat and use that to form the anterior chamber, create the space.
I think this, what you do is absolutely makes more sense, because after putting viscose, you try to put heel on, it blops out, comes out, it
Correct. Yeah.
doesn't stay in place as much as we would like to be.
Absolutely. I also have noticed this thing.
Yeah.
It's a good modification.
Yeah. So the capsular rexus is then created. Of course, we have the
so just one question, Harpriya, if there is a pseudo exfoliation ring, like in this case, you completely avoided it, but if it was, say, more central in location, would you encompass it, or or it doesn't matter, or avoid it, or it doesn't matter what level?
Please say that again, ma'am. I didn't get the question.
There's a ring of pseudo X which is there, and in this, capsular rexus was inside the ring.
Yes. So I think it would, if it were within the rexus, I think it wouldn't matter. I would go over it.
Okay.
Because it is more in the periphery, the rexus is smaller. So with the pseudo exfoliation, zonules can be weak, and so with the hard cataract, I don't feel any significant zonular weakness. The step when we assess, we actually feel the zonular weakness is during the capsular rexus. That's when you'll see a little more wrinkling if you're having weak zonules. I'm taking a lot of effort for the hydrodissection here multiple times, because that can actually help to, phacoemulsification, and also give less stress to the zonular apparatus. Or viper tama. phaco. So my vacuum is a little higher here. So last case it was 475. Here it is about 600 vacuum. So my IOP is 44 and 38 flow rate. I'm doing a vertical chop in this case. It's a little harder cataract than the previous patient. So I'm doing a vertical
Chopper
chop.
also looks as though, it's a different kind of a chopper, or it's the same
It's
chopper?
a different chopper. So this is Dr. Mohan
It's
Rajan's chopper.
sharp,
Straight,
sharp.
yeah, with a sharp tip.
Okay.
So this is a good chopper for a vertical chop.
I saw that you did use Verion in this, plus you marked manually also.
Yeah, so yeah, I actually do that because sometimes we have different surgeons operate, and some of the theaters may not have the
Okay.
Varion system. So we do that as a routine for all our patients. But I do use the Varion for all my toric cases, and that really helps. So for the vertical chop, I'm doing a little trench in the center, and then I wait for the vacuum to build, place the chopper from above below, and then chop. So in contrast to the earlier horizontal movement, this is a vertical movement. And in a case with pseudo exfoliation, you want less stress on the zonules. So you want to, a chop technique is good because you have less pressure on the zonular apparatus. This cataract also, you want to have it broken up into as small pieces as possible. Once your pieces are smaller, you'll find the aspiration is much quicker in contrast to having eating up larger pieces. So you find that it kind of disappears into the phaco tip. And again, though my vacuum and flow rate are higher, I use the same IOP and my chamber is absolutely stable, which means I don't have to. Right. Which means I don't actually have to. So you break it up into smaller fragments and then eat it up.
So the patient has
So
had
kind
a,
of,
yeah, sorry.
yeah, so you aspirate it at a normal depth because you're having a good chamber stability. You don't have to come closer to the endothelium. So PXF also you can have endothelial damage.
Yeah.
So epinucleus. Last piece, I would normally step down my vacuum to be on the safer side. Adrenaline. So the pupil has come down slightly. So when it does, I would like to use adrenaline just in case there is an advantage of additional pupillary dilation, because in a toric lens you want to have better visibility, and I do that before I inject any viscoelastic saline.
Also, phenocaine is there, which is got.
Absolutely, yes.
Yeah,
So phenocaine is a great drug which is very useful. Lens Franco.
We can see a large scar of the pterygium.
Yeah, the pterygium scar.
And it's indicating very well that it was beyond 2 millimeters of the cornea. And that is why a sequential surgery has been planned.
Yeah.
So,
Center. So with the cortex aspiration, I would like to go on a circumferential pattern. So we did a large trial called the Aravind pseudo exfoliation study, the APEX study. We are actually randomized patients with pseudo exfoliation, mild disease without phacodonosis, to either the 3-piece or single-piece Acrisoft lens, and to with and without CTR. And actually, we have just finished our 10th year follow-up. It's a prospective multicentric trial. And at 10 years, we found the risk of decentration or dislocation. We also had a control group who did not have pseudo exfoliation. And we found the risk of decentration dislocation was not higher, not very high in the PXF group, maybe just 2 or 3 patients amongst 1,000 whom we had in the study. And there was no difference whether we used a CTR or not. and there was no difference whether we used a single piece or a 3-piece IOL as well. So only in patients where we find we have pre-op phacodonosis or intra-op zonular weakness, I think CTR is indicated. If you don't find it intra-op, I think we can avoid a CTR. So I'm going to be implanting a toric IOL. So the toric lens basically is a wonderful solution for patients with pre-existing astigmatism. So it's on the aspheric platform. It goes in through a 2.2 millimeter incision. So my SIA is about 0.2 diopters. So the first step here is once the IOL is placed in the bag, removing all the viscoelastic from above the IOL and then from below the IOL as well. And then we have the Varion here, which gives us an idea of the axis. And that can be used to align the optic, the mark on the optic with the mark on the Varion. So that has to coincide.
Yeah, we can very clearly see that it's coinciding.
Yes.
Yeah.
So also when you form the chamber, I don't make it too, I just form it well and hydrate the incision and side port, not too tight. Again, because then the IOL can rotate more freely. So you just form it well enough and ensure when you form the AC, your IOL is still aligned well with the marking. So we can see the pseudo exfoliation. Also in the 10-year apex, the 10-year follow-up, we found a couple of eyes with corneal decompensation as well in the pseudo exfoliation group.
Okay.
So there is definitely a higher risk of endothelial damage in eyes with pseudo exfoliation.
Any late glaucoma in these cases?
We did see glaucoma later on. So because we took more of the mild disease, many of them did not have glaucoma to begin with, only a small number, but many more were added on over the course of the follow-up. But each year we had more and more patients with glaucoma.
Yeah. So very nice demonstration.
Yes, I'm sorry.
Alignment of the toric implant. Sometimes, as you said, that you do marking as well and you do Varion. Suppose if there is any discrepancy, any discrepancy in the axis of of marked axis and the Varion axis. So what do you finally decide? Do you?
I use the Varion. Yeah, I do unless it's a gross difference. And I think the Varion for some reason does not make sense. I think almost always, I think with the newer version of Varion, initially we were more skeptical, but we've been using it for many years and they have made various changes. And the newest version, which is being used, I think is very reliable.
Yeah.
So I would use the Varion maybe 99 out of 100 cases.
Have you used Aura, Harpreet?
No, I have not.
Okay.
I have not.
Because we've done a study where we've compared toric IOL implantation with Varion and Aura, and almost 90% of the times they agree with each other, but 10% of the times, there is a difference because and sometimes what happens is that you don't get that no rotation required NRR on Aura.
Right.
So invariably, if you go by Varion, like you said, Varion is really very good. If you go by Varion, then it always you're always hitting the target.
Yes. Yeah. So I think in spite of it, the IOL may still rotate post-op. Of course, the incidence chance is less, but I think it's more risky in patients with the rule astigmatism and oblique astigmatism, and patients with high cylinder, because there we have to use a toric model like a T8, T9, and even a small rotation can have a significant astigmatism. So when we do have to reposition a toric lens, it's only mostly in these instances, either in patients with the rule or oblique astigmatism, or patients with high cylinder, or in high myopes, where again the capsular bag is very large and the IOL can be kind of not optimally sized for the capsular bag, and there could be some rotation.
I know that you've done a very large study comparing your Orolab toric, if I'm not mistaken, with other toric lenses. Or can you tell us about that?
So that study, we had compared the Orolab's hydrophilic toric with the Alcon hydrophobic toric. And we found the rate of repositioning was similar with both these two lenses. I think in terms of absolute rotation, we probably have a little more rotation with the hydrophilic, Orolab hydrophilic than the Alcon hydrophobic platform. But it's not that we reposition all the IOLs which had rotation, only if it is significant, like more than 15 degrees, or the patient has 1.25 diopters or more cylinder, do we go in for a repositioning. And when we looked at repositioning rates, we found no difference between these two lenses.
Okay, so I think your next case is also ready.
Yeah, so we're just going to be there in a minute.
So the next case is again immature.
On a slide coming in? Yeah.
It is there with posterior subcapsular cataract, and visual acuity is 6/24, axial length is 23.11, with a cylinder of 0.56, K1 44.7 and K2 45.2. So we are going to be having an implantation of Vivity intraocular lens, 21.5 diopters.
Yes. So we're planning the Vivity lens. I think there is a lot more focus today on presbyopia correction along with cataract surgery. And thankfully, we are at an era when we have definitely much better options. And the Vivity IOL, the newer EDOF lens from Alcon is a wonderful lens where the patient gets excellent intermediate vision and excellent functional near vision as well. So this patient actually, for the Vivity lenses, the target we choose is a 0.3, because we find that with that they are even able to, many of them are even able to read N8 or even N6.
Minus 0.3, right?
Yes, minus 0.3, yes. So this is also a little harder cataract, and I'm planning a Vivity IOL here. So in a harder cataract, the capsular rhexis, it's better if it's larger, so you have more working space. This is much more important in an SICS surgery, obviously, but phaco as well. If you have a little harder lens, it's better to have a bigger rhexis, so you have enough space to elevate these fragments, which are a little more difficult to maneuver. So here, and the capsule also is thinner in these harder cataracts. So you can make a little larger rhexis quite easily without the risk of it going to the periphery. So there's a subcapsular component as well to this cataract.
You've done SICS also, Haripriya, and you in the past, and I'm sure, I mean, is there any occasion when you do it now?
Yeah, but I think, of course, with the better machines, the need has come down significantly. But I think, yes, there are cases where I still prefer an SICS, and a lot of advantages to knowing the technique for sure. So it's a grade 3 to grade 4 nuclear sclerosis. And I'm using a higher torsional ultrasound here, torsional power here. So it is 75 Ausl. So when we work with harder cataracts, it's important to have more of the phaco tip exposed. So retract your sleeve a little more so that you have at least 1.25 mm of the tip exposed. So then you can get a deeper hold on the nucleus. And again, the chopper also, this is again Dr. Mohan Rajan's chopper, a long 1.25 millimeter chopper with a sharp tip. So this will help to separate the posterior fibers. So you can see that a lot of the tip is actually exposed, but you will have to have the sleeve placed such that your irrigation ports are still in the anterior chamber. So again, in the vertical chop, what I'll be doing in this hard cataract, I normally start with a little burrow in the center, and then I go in completely occlude and then do the vertical chop. And then you'll have to probably continue to hold and then place the chopper a little deeper if required, and wait to see if your posterior fibers have broken completely all the way to the center. So you can either re-occlude the tip, or at the same side you can continue to hold with vacuum and replace the chopper again. So I will ensure I complete the first chop, place it down, the lower half, chopper is placed, and separate. So wait patiently and separate, so you see that all the fibers are broken up.
This
So now
is a very, very nice, very good tip, that in a hard cataract, it's very essential to have two pieces which are absolutely separate. Even the posterior plate is separate. And that's why you rotated and did it from the other side also, so as to
exactly
separate.
So again, then before I emulsify any of the pieces, I like to have it smaller. So chopping it, so I like to have at least 4 pieces of from each of the hemi nuclei. So make it into tiny pieces. So the smaller the fragments are, less energy we use, easier to aspirate, less endothelial damage. So if we can make it smaller, I think that much clearer your cornea will be on post-op day 1. Again, viscoat also helps to ensure we have clear cornea. Aurolab also makes Aurocoat Plus with chondroitin sulfate. So anyone which has chondroitin sulfate will help to have a clearer cornea. And then once the pieces are broken, emulsification happens at a deeper plane. So again, if you see I'm using higher 75 here.
And you use intelligent phaco as well?
Pardon, please say that again.
Do you use IP as well?
IP
I use IP. Yeah, I have IP on for all my cataracts actually.
I don't know. I feel when you use IP, the followability kind of gets better.
I think so too. Yes. Yeah. So that's on for all the. I don't use any traditional ultrasound besides the IP. So use the second instrument well also. That also helps. Use some of for the mechanical aspects to feed the pieces, separate it. So for all of that, if you start using the second instrument more, it makes your procedure that much better. Lens. Epinucleus. So also removing the epinucleus bowl, and before going in for the.
So you go to the epinuclear mode in the Centurion machine.
Yeah. So, I mean, as you mentioned, I think the foot pedal control is essential. So we're able to manage the vacuum well for the different modes. Sleeve marketing.
So with such a hard cataract, I think CD of 8.5 is a very good one, because that was possible only because you could you had broken the nucleus into multiple small pieces. So wonderful tips of how to do a smooth phacoemulsification in very hard scenarios. So you are used to using coaxial irrigation aspiration?
Yes, I do use the coaxial irrigation aspiration for all the patients. I think a bimanual probably, maybe if I have a PC rent or something and I want to have the irrigation away from it, then I may use a bimanual.
Bimanual or a small pupil. I think, I don't know, I find coaxial to be much faster and much quicker. And I feel it takes into account, I mean, it aspirates thicker cortical sheets as opposed to bimanual, for which, you have to, you spend extra few more minutes to do it.
Exactly. Yeah. I think we're all been used to the
same mode,
coaxial
yeah,
system. Yeah. So this is the Vivity lens, which has been implanted. And like I said, we have had actually very happy patients, many, especially if they are early to early to moderate presbyopes, like between age 40 to 55. Those presbyopes, I see many of them are even able to see N6 with the Vivity lens. For patients who are, beyond that, who have more than 1.5 or 2 diopters presbyopia, they probably need little addition for near vision. But otherwise, I think it's probably to do something with their little accommodation which they already have or something. So they have good vision for distance, intermediate, and near. And also, we have had a good experience in patients post refractive surgery. We have been placing these IOLs. And they have been very happy with the quality of vision too.
And as you said that you keep a target refraction of minus 0.3.
Yes.
So I guess because of that, the patients will have a good distance vision as well. It may be 6.6 partial, but it will be very good and a reasonably good near vision. So when you implant the lens in both the eyes with that kind of a target refraction, the patient will have bilaterally 6.6 and close to, maybe N8.
Yeah, absolutely. I think there was one interesting paper at the ASCRS where they plan a 0.8 residual in the non-dominant eye. And the patient actually had excellent binocular vision. So I think if you have a little residual, it definitely helps. A minus 0.8, yes.
And it will be really wonderful to see, look at the aberrations of these lenses, because the diffractive plates that are there in many of the lenses, they create many of these aberrations because it splits the light and all those. But lenses which do not have diffractive plates all throughout, they might be better off in terms of better aberration profiles.
That's true. Yeah. So I think that's something which it's, I think we have a lot more to explore on these platforms for sure. Yeah.
Because what I feel is that these days we are having very good lenses which can provide 6.6, N6, and even good intermediate vision. But I guess the time has come now that we have to think about the aberration profiles.
Absolutely. Yeah. Which is the biggest concern today, why we're not able to implant more of the other multifocal lenses. So that's where maybe these lenses would help a little more.
And many times that's why in conditions wherein in diabetics, we are a bit hesitant in implanting any of these lenses. We prefer, say, monofocal, or in such cases also, if the aberration profile of these lenses, if it improves, then if somebody who is not having a frank diabetic retinopathy, one may go ahead and particularly who is, say, 60, 65 years of age, not having diabetic retinopathy and a good glycemic control, one may consider putting these lenses in.
Correct. Yeah. That's true.
Yeah.
So we have one more last patient. Shall we go ahead? Or?
Yeah, please. Yeah. So can we have the details of the fourth patient?
Slide, Martina.
The hard mature cataract with pseudoexfoliation, moderate dilation. As we know, in pseudoexfoliation, dilatation is again an issue. Visual acuity, hand motion close to face. Axial length is 22.30. There's a cylinder of 0.67. K1, K2 45.46, 46.13. And the IOL that has been planned is an acrylic lens plus 22.5 diopters. And this is a monofocal lens?
Yes, it is a monofocal lens. It is. Okay. Yeah, so I'm actually a little skeptical on doing multifocal if I don't know how the back of the eye looks.
Okay.
Normally we do an OCT in all these patients, and we
Yeah.
do. But if a patient really is keen on a
Yeah.
multifocal, then we would do it. But otherwise, we normally would recommend a monofocal.
Yeah.
So as you can see here, this patient has some pseudoexfoliation. Can you see the microscope view?
No, we can't see the microscope.
Yeah, I think we'll just change it now.
Yeah, now it's there. Now it's there.
Yeah, so there is some pseudoexfoliation. And there is also it's a mature cataract with the
Yeah.
brown component and some calcified anterior capsule as well.
So
That can make your
sure.
So I think these lenses, the stain is very useful.
Yeah, that's true. And maybe a couple of things. What is the lens thickness? And I mean, in such cases, it's
Anjana, what's the lens thickness? This good. You have the lens thickness. This show me the A-scan sheet. Yeah, I think we don't have that printout here right now.
it appears to be a thick lens only.
Yeah, appears to be a thick lens.
Yeah.
Yes. So I think in a this is one case where I would use viscoat and
Yeah.
use I'm using high whisk here below that, so that I need to form the anterior chamber as well, because the chamber is slightly shallow with the thick lens drops on the cornea. So otherwise I would just use HPMC below the viscoat, but here I would like to use a high molecular weight viscoelastic.
Okay.
Forceps. So the rhexis is, I'm trying to make it a little larger beyond the fibrosis zone. So I try to include them as much as possible, because if I go over it, then that could be a weak spot, and that could be a site where the rhexis can extend. Phaco. I don't do a hydro dissection in patients with mature cataracts because the nucleus is already mobile, and I would like to have whatever little epinuclear support is available present up to the end of the procedure. So following capsular rhexis in a konja periya chopper, I would go in for the phacoemulsification. So in a white lens, I think the biggest challenge is for the capsular rhexis. Now this is more like a brittle cataract.
Can we have the microscope view? We are not having the microscope view. Oh, yeah.
Microscope view, yes.
But it's...
Yeah. So this is not a very hard lens. It's more of a brittle lens.
The microscope view is frozen. Yeah, now.
Can you see it now? Yeah.
Yes, yes, yes. So you're using the same...
Drops on the cornea?
Same chopper?
The same chopper, yes. So with the vertical chop, I do the horizontal or the vertical chop.
Okay.
Now, a slightly oblique motion could also be useful, slightly from the periphery, and then, kind of a diagonal movement can also combining the horizontal and vertical movement can also be useful to chop in these cases. In a mature lens, I think the absence of epinuclear bowl does increase the chance of having a bare PC and a PC rent. So again, it's very important to have a good fluidic system, and you only take the pieces one at a time. If you have one piece flying freely in the anterior chamber, I would normally take that piece first and then eat the other pieces in the bag after that. So with the, so you can see these pieces are stuck to the endothelium. This is because of the viscoat, and the air bubbles which were there initially are still there. So this means that the viscoat actually does stay almost till the end of the procedure, which is why it is, just injecting it once works well, actually is quite adequate in most instances. So you see the air bubble is almost still, it just is kind of stuck to the endothelium, which means the viscoat is still there on the endothelium. So you have to, when chopping, the most important is to be able to continue to occlude and hold vacuum and then move the chopper. Lens ma indicating quadrant. Red low epinucleus.
There's hardly any epinucleus. It was all nucleus only. So
yeah. So again, these cortex, whatever we have in these mature lenses can be quite sticky. So again, just washing the bag, equator of the bag. So it loosens up the cortex, whatever little is stuck there. Visco. This is again a single piece Acrosoft iron, which is being placed in the bag.
you have not used the aspheric one?
I did not use the aspheric. The patient has a clear lens in the other eye as well.
Okay.
So if you want to lift the optic, just hook on with the Sinsky, move to one side, and then aspirate the viscoelastic below the optic. Antibiotic.
There's so many discussions. People, I'm just going a little off track, or maybe you just finish the case, then maybe we can discuss about that.
Nalla panniyaachuங்க.
So wonderful surgeries, and you did it very smoothly and in a very short time. I just wanted to have your opinion on these the lenses. I'm going a little off track. That people have different views regarding placement of clear lens and yellow lens in pediatric eyes. Some people feel that these yellow lens should not be put in pediatric eyes. Some people feel that there's hardly any evidence that goes against it. So what is your usual?
Yeah, so I personally don't do many pediatric cataracts myself, but the pediatric ophthalmologist normally do prefer a clear lens here as well. I am not sure. I don't think it's any fear or anything about the aspheric, the yellow platform. But again, I think since there's no evidence in terms of benefit, I think that's the reason why it's not being used widely in children.
Yeah, true. Actually, this discussion came because I have been discussing this thing in various forums, but till date, actually, because there's no evidence whether the yellow lens is detrimental or it produces contrast in children,
Right.
or whatever that has been claimed, there's no proof of that. So
Correct.
since we were discussing, I thought let me just put in a word about this. And another thing that what I would like to go a little off track from here, since you have so much of experience, placing the multi-piece lens in the bag sometimes can cause some folds in the posterior capsule. Have you noticed that, or it's just?
I think it can happen with any of the lenses. And I think normally if this can happen, especially in, I think, much older patients when the capsule is more
A little,
more fragile, thinner.
yeah.
I think it can happen more there.
Yeah.
It's good to talk to the patient pre-op that they may need a YAG laser in the post-op. If your capsule is fibrosed, anti-capsule is fibrosed, or if you think your capsule is stretched over the lens too much, because they may need a YAG laser within a couple of months. I don't think there is, this can even be seen in the post-operative period. Sometimes it looks fine on table, but in the post-op, you may see a few folds. And if the patient is very sensitive, then I think we would consider a YAG there.
Yeah. And it was really wonderful because every time whenever we have your Surginar, there is some new tip that you give to all of us. And the one that you gave in cases of myopes, that you lift the iris, and it really showed actually in the case, because we could see that the AC was not getting very deep, and the patient definitely will not have any symptoms. So that is something which was really very wonderful tip, apart from the wonderful surgeries that you showed. Very smooth and very, very nicely done. So I would like to thank you and all your staffs who have managed to get the surgery done. I mean, obviously you need your staffs as well. So I mean, you can call maybe if your sister or your there.
Anjana.
Yeah.
So yeah, thank you so much, Namrata ma'am and Dr. Rajesh, again for this wonderful opportunity. Thanks to AIOS and the wonderful team we have here. Natarajan Vanga. Natarajan is also from Alcon, and this is our nurses and our fellow who have all helped to put this together. Really appreciate this opportunity, and thank you so much.
So thank you very much, and I would like to thank you and your whole team, as well as Alcon, for bringing this wonderful Surginar from Arvind Eye Hospital. And definitely we would like to have you again after some time, and one of the Surginars. And till then, thanks. And
thank you. Thank you. Have a nice evening. Bye-bye.
Bye.
The mic up.